Hi, Audrey. Good morning.
Hi.
Yes,
Hi.
I just want to say thank you first. Thank you so much for sparing half an hour to join our program. Yeah, I
Pleasure.
understand you are very busy pediatric ophthalmologist. You must have a very busy clinic. So
Well, when it happens.
yeah. So I just wanted to give you like an overview of the program that we are running at the moment. We call it a Future Leader Program, and then this particular interview we call it Interview the First Author. So the idea is really to interview the people who really run the study, and then to understand the story behind the research and the paper and so on. By broadcasting all these videos, we try to inspire junior or young doctors to involve more or participate research project. At the moment, we're targeting doctors in China, but we also broadcast this in YouTube and Asia Pacific channel as well. So welcome to our Interview the First Offer program. I understand you are the key person running this ATOM2 study. So the purpose of interview, I try to understand more details about ATOM2. And then I also very keen to understand how do you adopt this finding? I mean, atropine or low dose atropine, or even high dose atropine in the clinical practice.
Okay. So basically when I returned to Singapore in around about 2000, they were already doing the ATOM1 study. So at that time when I came back and I was a little bit involved in that, I was going to the clinic. They had a clinic run at the Polytechnic, and it was guided by, at that time, Vivian Balakrishnan, and then later by Donald Tan, who took over later, and a few people were involved in the program. So there was a really established ATOM1 program, which was, of course, 1% atropine versus placebo. So from very early time, I could see how the clinic run, how they randomize, how they sort of like mask the people from one team to the other, how it was collected the data, how it was inputted the data. And then when the database, I went off for my fellowship, came back. And then when I came back, the database was there. So it was something to play with, a nice, clean database. The good thing about randomized control trials, well run, is that you get a very good database that is nice and clean and all the data values are inputted. So when you want to analyze it, you feel confident that, okay, this is good data and my values are going to be, sort of like very representative of each group. And it was nice that, as you go through, you understand that, it's very important to, how you randomize, how you get different groups so you get a balanced group, and then also not to randomize like in too many groups, and what's a good optimal level and things like that. So learn all that in ATOM1 basically. So ATOM1 and it started 1996, ended around about 2003, 4, like that. Yeah. And then we started planning ATOM2. Okay, so at that time we sort of like said, okay, well, ATOM1, at 1% atropine is really powerful. It can really slow down. In fact, you get this hyperopic shift and everything. So it was a really good thing. And then the next thing was, okay, could we use other doses? Okay, so and we also wanted to do a longer study. So initially we had 1%, then the second ATOM2 was 0.5, and then 0.1. And then we said, okay, can we justify a pure placebo group? Let's put 0.01, kind of stuff, a very, very small dose that, probably we a placebo group, but at least it's something there kind of thing. So that was the plan. Then when you do it, then you got to think, okay, what's my sample size, how to calculate sample size, and then what your age group is. So we followed a lot of the protocol from ATOM1. We already had it. We had, okay, we want a 6 to 12, we want what range, wanted to be similar so we could compare it with ATOM1 with the 1% going forward kind of thing. Of course, there was 1 decade apart. So the planning came on over there, and we then, because the hardest bit is getting funding, okay, and the funding came on, and so we started the study. Already that time we had good associations with a good monitoring program. So someone would come in and monitor and stuff like that. We had a good team that knew what to do from ATOM1. So the team carried on from ATOM1 to ATOM2. So it was actually building on what we had before, and then you go on and then you did the study. And the frustrating thing is waiting for the results to come through. The recruitment was very fast with ATOM2. We managed to recruit around about 6 months, 8 months. We had a very fast recruitment. So the next step was just to follow up the patients and then make sure we don't get too much dropout, because it was a long study. We had 2 years and then we had washout, and we had another sort of like 2 years. It was a 5-year study. So, and everything's blinded through that time. So we had a bit of reporting in between. So at 2 years data, we analyzed it, and then washout, we analyzed it. And then after that, end result, we analyzed it. So there were 3 different papers that went through it, and as well as other and other things that we looked at as well and published along the way. Yeah. So a long journey.
Fantastic, Audrey. I think this is I actually remember the ATOM-1 study was published in 2006 something, and then in 2012 you published the first 2 years analyzed for ATOM-2, and then 2015 I think is you published the 5 years data for the ATOM-2. So this is a great study, landmark study, really. I mean, share with the evidence to the world that this low dose atropine 0.01 is effective and safe. What you are saying is that 0.01% atropine was actually chosen as a somehow possible in your ATOM-2, but unexpectedly you find out, hey, at 0.01% atropine actually got a better control and next rebound. Is that correct?
Well, there's actually, if you look at it, it's a dose-related response. So you do have 1% being the highest, and 0.5, and then 0.1, and then 0.01. But it was surprising in the ATOM-2 study that the 0.01 did so well. If you look at it, it's almost catching up with the 0.01 and 0.5. In fact, there was no significant difference at the end of 2 years between the 2 groups. But there was a little bit of a caveat, because what we did was we said, okay, in the placebo group, we also cut down the size to half. Okay, so it was 2 to 1, because we didn't want to put too many people in the placebo, because you know what happens in a group that doesn't work so well for a long study, you get dropout. So because people decide, oh, my child's myopia is still going up very high, so they will drop out, and then you have less. So, but we did have quite a good follow-up right to the end for the 2-year study, so we're quite comfortable that that was. But if we had known, we'll put like an equal proportion in each group, because that would be a better result. But we did have that 2 to 1. So a lot of things. That was a surprising result, which was a good result, I think, because it then led to the idea of low dose atropine. Although high dose atropine also works very well. So if you wanted to use it clinically, that's also an option.
Yeah, wonderful. You did mention the high dose atropine. Like I think the ATOM-1 is talk about 1% atropine, and then later on you look at 0.5, 0.1%, and 0.01%. By looking at the 2 years data, I mean in the ATOM-2, actually we can see the ingredient, I mean the efficacy actually reduce over all concentration. From 0.5, 0.1, and 0.01% control. And then also looking at 2 years data in ATOM-2, actually people keep asking, how come 0.01% atropine got a better control in terms of spherical equivalent change, diopter change, but not in terms of axial length progression. So I'm very curious to understand in terms of like comparing 0.01% and the placebo in ATOM-1, and then the level of axial length elongation is quite simple. Yeah.
I think there are a few things there that were difficult. Okay, so firstly, we used different machines to measure axial length between the 2 studies. So for the ATOM-1 study, we used the B scan, which of course you put numbing drops in, crying kids, you sort of like do a B scan, which is fine. I mean, you can do the B scan. And then for the ATOM-2, we did the IR master. There's also a difference in spherical equivalent baseline between the 2 studies. I think with the ATOM-2, it was slightly higher spherical equivalent than ATOM-1. I think it was almost like a diopter difference. So the baseline spherical equivalent axial lengths were also different. And the question whether that made a difference or not. Also, if you look at the ATOM-1 study, the increase in the placebo group was actually very low. Was 0.2, which is very, very low compared to the other studies where you can maybe get, sort of like a much greater, like 0.4, 0.5, like that kind of stuff. So the placebo group in the ATOM-1 study, the axial length, the spherical equivalent was quite big, but the actual size of eyeball was quite small. Okay, so really much smaller than the other studies that you look at, which were a lot higher. So in other words, comparing a very much, I think it went up 1.2, and then went up. Can't remember the exact thing. I wish I had it in front of me. But it was lower, okay, than what you expect, because you expect about 0.3, 0.4, 0.5 per year. but this was a lot lower. So when you compare a very low placebo group in atom 1 versus the others, then the question was, okay, was there error here or what happened and kind of stuff? But you have the data, you can't do anything that's data kind of stuff. So without having a placebo group in atom 2 really made it difficult. So we're scratching our head and saying, okay, is there it looks as if there made no difference for the atom 1 placebo atom versus the 0.01% sort of like in atom 2, that kind of stuff. Now we've since done another study actually looking at even lower doses of atropine. We looked at 0.01 and then 0.005 and 0.0025 and then placebo. So at 4 arms, we actually did another small study where we looked at even lower doses, and this was done with Santen, a Japanese company, kind of stuff. I think we've done some posters, and we do find that in that lower group, even in that very low range from 0.001 to 0.0025 to 0.01, there is a graded change versus placebo. So there is an effect. It's just that it's sort of like, we didn't see it between the atom 1 and atom 2, but there is that effect. Now, there is an argument also with the low dose that yes, it seems that the spherical equivalent impact seems a lot stronger than the axial length impact, and that's something that is we acknowledge and kind of stuff. So it's something that as we do the clinical practice, what dose we use, it's also important to look at both values, spherical equivalent and axial length, and see. I think the effect in the older children might be less than the younger children. So if you include very, very young children, like going down to 6 and 4 and things like that, you're going to have a lot more difference between the spherical equivalent axial length than you would in the older children. That's our clinical experience, because some of the younger children, they're going up very high. If you look at the ones that are not on treatment, sometimes they can go up 0.6 a year. Sometimes I've got one kid that went up 1 millimeter a year and only had a spherical equivalent of one diopter. So it can be quite wacky in the young age group, the 4 to 6 age group, in the very young group. Yeah. So these things are interesting. We'll try to work out, but what we find that in every individual child in the clinical, when you look at it clinical, it can be so variable. So I think you have to just treat each child individually and see how they progress and then go from there. It's nice to have axial length data beforehand, but a lot of time we don't, because nobody measures axial length outside in the shops and stuff that much. So all we are based is spherical equivalent before, and then axial length starts on the day you see the patient. And then the question is whether you follow up a bit to see what happens in 6 months before you start treatment, or whether there's this pressure to start treatment. So unless we do have another clinical trial that looks at spherical equivalent change, axial length change before you start treatment, or like the placebo group versus non-placebo group, swap over kind of stuff, we may not get that answer. Yeah.
Thank you, Audrey. So going back to the efficacy at different concentration of atropine. So now the LAMP study becomes the evidence. So 0.05 in clinical practice. So how do you consider this different concentration? Like what some people still use 1%. I mean Taiwan, and then how do you consider 0.05 and 0.01, for example, in your clinical practice?
Yeah. So I mean, we use we've been using 0.01 since 2013. So we've got quite a lot of experience with 0.01, and we know that in the younger children sometimes it's not enough. We need to go something. So before we got other doses, we've been just using 0.01 twice a day, which is, I suppose, equivalent to 0.02 kind of stuff, in a way, just thinking in your mind. So now we have the 0.025. We do also have 0.05 in Singapore. We have 0.1. And then we have the 1%. So in our clinical practice, we have a luxury of lots of different options. So it comes to discussion when the patient comes in. When they're younger, I tend to want to start on a higher low dose rather than a low dose. But if they're older and they're not so progressive, sometimes the lowest dose work. But if they want to be extra careful and want a higher dose, then that's also available. I think the effect then comes the balance of efficacy and side effects. Some children are fine, even with the 0.1, they're fine. They cope very well, and they don't need any progressive glasses or tint. And other children really, even with the 0.01, they start complaining. So it depends again on what dose you can have the effect that you want in both pericoclear and axial length without sort of like giving to them too much side effect. And now with the combinations, then the very low dose becomes very useful because it can say, okay, let's start both very low dose first, so not much side effects. And if it works really well, and I've done this with some combinations, especially the glasses model, and they work quite well. And then the question is, okay, which one is working more? And then the question is later on, okay, the eye drops very amenable to tapering off and then seeing and things. But parents sometimes don't mind putting a very low dose with very low side effect together until they're teenager, and then we can sort of like stop them. So it depends. It's very individual, and I think sometimes you get surprised. Some kids, nothing works. The glasses will work, the contact lens will work, the atropine won't work, and you just have to accept that some children you cannot help. Yeah.
Yep. So in your clinical practice, assuming you have a 6 years old child come for your practice and it's -2 diopters and it's progressive, like in the previous 12-month progression is greater than 1 diopters. So in this case, 6 years old or even 5 years old, quite young. So would you initiate like 0.05? Do you think it's safe to initiate a bit like higher dose, like low dose atropine, like 0.05, for example?
Yeah, I mean, you're talking to someone that used 1% almost every day at the very beginning, okay, to after where I taper. So I've been using 1% for 20 years. So to me, it's not a huge issue, but so 0.01, 0.05 sounds very small compared to 1%. So a little bit depending on how anxious the parents are. Sometimes I will start them on the 0.025% just to see how they go for a little bit, make sure they got no side effects. And then depending on response, I could go up, kind of thing. Yeah. If I needed to. Yeah.
Yeah, I really agree with you. In China, because the atropine is really new, a lot of people or junior doctors or even senior doctor, they worry about safety. Because I understand in Taiwan, in Singapore, people has been using 1% atropine quite a lot for the progressive myopia. They just prescribe is it photochromatic lens?
Yeah, that's right. Yeah.
A progressive additive lens, so that children can manage their side effect. And then most of the side effect is manageable. But then I just wanted to a little bit like learn from your clinical practices experiences that, say for example, for 0.05% or 0.01%, how many of your patients they do not require photochromatic lens or PAL lens at all? I mean, on this low dose.
Yeah, I mean, I could 0.01%, we have a lot of experience, so I can say that almost all children don't need it, but there may be 1 or 2 that is sensitive, then I don't mind giving it to them. We have a letter we prepared for 1%, which I still use, okay, and just give it to them. For the 0.1%, about 50% of children might find they need tinted glasses and things. But I understand, speaking to some of people who work in Australia and Europe or UK and America, that basically very, very sad. Some of the Caucasian kids, even 0.05%, they cannot tolerate, and even 0.01% is tough. So I think it depends on number one, how you approach it. Sometimes the children and how what the parents and children expect and things, but and how much you ask, kind of stuff. So but we tend to have not much problem in our Asian kids, yeah, with 0.01%. We've now started 0.025% for around about a year, 6 months to a year now, and so far so good. But if they need it, I just give them the tinted glasses. If they need the progressive, I give them the progressive. It's not a big issue, except it's more expensive for them for the glasses when you have the tinted and whatever. It does increase the price quite a bit. Yeah. But if they need it and they can afford it, that's not an issue. Yeah.
Audrey, I think you raised a very valid point in terms of ethnicity and efficacy. So I understand in Europe, they are just Agosto just initiate a study, they call it CHAMP, CHAMP UK. So the idea is to understand what is the low dose 0.01% atropine on the European kid, I mean, in terms of controlling myopia. So I understand in the ATOM2 or ATOM1 study, majority of the study participants, maybe 95, 97%, they're all Chinese.
Chinese, yes.
Yeah. So, but then in your clinical practice, I'm curious to know how effective is this atropine among India and Malaysia children, for example?
Okay. No, they also work. Okay, they can work. Now, the Indian children are very interesting. Okay, because it's a bit of a mix. Now, I don't treat them any differently. I do have a whole subset of young Indian children, first generation myopes. That means their parents came from overseas, and they are just being brought up in Singapore. There are 4 to 6 that parents are not myopic at all, that get very aggressive myopia. So I can imagine what's happening in kind of stuff in some of these young children, but it's interesting. I have to subset maybe because I see quite a lot of Indian kids in my practice for some reason, and so we have to be a bit more aggressive with them. The interesting thing is how we combine it at the moment with the glasses and the contact lenses and things. That's something that will be, as we go on and we learn a little bit more how we combine and things. I guess the idea with the glasses is whether they work in the very young kids. And also the contact lenses, whether the very young kids can tolerate it. And of course, the long-term use of contact lenses over, like we're talking about, 10-year period and things like that, and whether there are any potential effects of that or whatever and things. So I guess it's so interesting because there's so many new things we can try and things. So how we mix it and match it and stuff. But if children want something, and in Singapore it's a relatively cheap medicine, then yeah, we try. And sometimes the children we just I still have children I have to put on 1% and still not working. So but we know that 10% of children may not work well even with 1% atropine. So the question is, how do we recognize that? And then what we try next, and whether those other treatment will work or not in this group where maybe nothing works, kind of stuff. So that is interesting, but because it's a very small group, it'll take a little bit of time to tease out, and we're just only starting to use a lot of the different combinations now. So hopefully in another 5 years we might have some idea about how what works when and when we should stop and things like that.
Yeah, thank you. So now we come to something like how to manage very difficult case. So if you got a children like start from like 0.05 or 0.025, it doesn't work. So you really have two options. Will you add ortho K in as like a combined treatment, or you simply increase the dose to 1% and also prescribe photochromatic and PAL? And let's put aside the affordability of a patient, assuming they can afford all this treatment.
Yeah, I mean, I'm going a little bit now to before we go to 1% atropine. So I think even with 0.1% atropine, we can combine, with glasses or contact lenses. But if parents are willing earlier, we can start combining earlier and see. The question is, in the really progressive ones, every time you do that, you cross your fingers, because if it goes out, you say, oh no, what I try next? And then if you stop the contact lens or glasses, will there be any sort of rebound from that where you change it and stuff like that? Because for the glasses and contact lens, it's basically all or nothing. You either wear it or you don't. There's no graded wearing and graded degrees and stuff like that. Whereas for the eye drop, you can always increase and decrease and play with the values and things. So with the combination, that's the hard thing. You try, if it doesn't work, then what you do, you take that off, put another one in, like contact lens will work, and put glasses on. Will it work then? And then as you're doing all that, of course, the degree is going up and up and up, and you're wasting time and things. So the question is, should I just give 1% and just, hopefully that will work, or do I try all these different combinations first and see? So in our practice, of course, it depends, because we're actually doing starting very soon a joint glasses atropine study, to see how that goes. A small one, just to see how they combine, especially in the younger children. So hopefully in a year we'll get some results from that. Glasses are quite easy because it's no risk. The question is whether it works in the younger children or not. Contact lenses, it depends on whether they've got allergy, whether they've got astig, whether they can tolerate it, that kind of stuff. And some children are fine with it. And I got one child which I really wanted to try, and basically was parents just gave up. They threw their hands up and said no, cannot. And then the kids started getting lesions and stuff, and said, okay, all right, we'll just go 1% atropine, because there's an 8-year-old, a 7-8-year-old kid, kind of stuff. So we'll just go from there. And she's holding, so we'll just cross our fingers and toes and see how she goes from there. Yeah. But we sometimes do get these tough cases, and it's a matter of talking with parents, understanding their needs, they understanding our limitations, and then making a decision, because contact lenses and glasses are not a cheap option. And then to try and know, okay, other things as well, like, the lighting and the outdoor and stuff like that, and things, and trying to see how we go, and working together with parents. And then in the end, some parents say, okay, try, we can't, it doesn't work. And then we just have to accept now that some children are going to be highly myopic.
Yeah. So assuming you have a very early onset high myopia patient, like 6-7 years old, minus 6 diopters, so will you consider high concentration atropine or low concentration atropine? Because some of these early onset high myopia patient, actually, we don't understand how this high myopia develop in such an early young age. But then the progression is actually not that much.
Yeah. So I think there is a group of very highly myopic 6, 7, 8 like that don't progress. So the first thing is, before you panic, do you want to monitor for a little bit? Because once you start, then you don't know whether is it your drop or is it, whether you needed it or not. Because once you start, it's hard to know what's actually happening. So if it's not progressing and you start trying to say, oh yeah, it's doing very well, but actually maybe you didn't need to drop in the first place. So that's always a possibility. So but it is tough, because I think the first thing in our mind is glaucoma. I mean, you're a glaucoma specialist, so the first thing is it glaucoma or not? And usually then axial length becomes important, and then, because sometimes even with sometimes you put atropine refraction to get the really lowest degree, you're not sure what with young children, how to get the actual degree and stuff like that, cyclo or whatever. So I would sort of like make sure no glaucoma, no other issues, the lens doesn't look funny, cataract, that kind of stuff. Vision is good and things. And then I'll just monitor for a little while. Parents are extra anxious about it, a shorter time, and see 3 months, 6 months, see whether it progressed a lot, and then make a decision. Now, I do have a child at the moment that I'm seeing that's 3 years old that has a degree of 900. Okay, and then it's sort of like, okay, so did the same thing, monitored. I just saw her second time 3 months later, and now she's 950. You go, okay, and her axial length, which was initially measured B scan to now IOL master. She 3-year-old managed to IOL master. I'm very happy, and it's gone up by almost like it's 22 to 23, and I'm going like, okay, she's gone up 1 millimeter in 3 months, and her spherical equivalent has gone up 0.5. How do I then marry these two things? Because should I be looking at the spherical equivalent, which has gone up 0.5, or should I be looking at the axial length that's gone up 1 millimeter, kind of stuff? And this 3-year-old kid, when they're growing really fast anyway, but the 3-year-old kid, you don't expect it to be 23, 24. I mean, that's not what they should be. So again, I spoke to parents. I said, okay, what are we going to do? Because what dose? There's no evidence that low dose atropine will affect in this group. So I think we've decided we'll wait another 3 months and then see how it goes another 3 months. Now that I know she can do IOL master, and then we'll have another look and then make a decision then. But her cut-disc ratio is 0.2. I got a picture of it. And her cornea thickness is 550, and her pressure 16. So I don't think it's glaucoma. But so we'll just watch and see. But it's really tough, Sometimes you get these kids and then when to start and things. But I think if she goes up again, I'll probably start her on a very low dose, either 0.025 first, and see how we go. And then
so maybe the patient is just stickler syndrome. Who knows?
Yeah, true. Maybe. Yeah.
So going back to the questions that our audience in China may be very interested to understand. So because in Singapore, you guys has been using 1% atropine for a long time, like maybe like 20 years ago, you already start use 1% atropine. But in China, nobody uses it. So people keep asking, if we use 1% atropine among the children when they're still young, like 7, 8, so when they grow up, with this 1% atropine, like a long-term use of 1% atropine, will really compromise or affect their physical development, how tall they are. I mean, something like that.
Yeah,
So you
yeah.
observe anything relevant to this? Yeah.
Yeah, I guess then we can look at our Atropine study, because we treated these children for 2 years on 1% atropine. And what we could say is that when we ended it and washed out and everything, was that, because we treated only one eye and then treat the other eye. Okay, so we had one placebo and one treatment eye. So we could see that at the end, when we washed it out, the accommodation and every pupil size and everything was similar, okay, in both eyes. So we sort of reckon that, okay, probably once you stop, it reverses to almost a normal range kind of stuff. We also did electrophysiology. These children to see whether there's a difference or not, and we didn't find any kind of stuff. We do know that very sadly that these children with myopia, their ERGs tend to decrease over time, but that's just because they're myopic and things like that. But it was the same rate in all the different doses and in the 1%. So we didn't see any functional changes, and we didn't see any physiological changes at that period. Of course, if you're talking about treating it for 5, 6, 7 years, whether that's an issue or not, that's a little bit harder to say. Although we do have some children that I have treated for 10 years with 1% atropine, and the child's now sort of like, he started, I think he was -8 when he started, and now he's already stopped the treatment and everything, and he's -9. So okay, have we saved something rather than the other? But again, I don't think we use 1% atropine every day now that much. As I don't know whether you've seen the more recent publication that we did, that gradually over time I've been reducing the frequency of atropine. So normally now, before we had low dose, I was starting them on once a week, twice a week, 1% atropine, and that would work. Okay, so you didn't need to put it every day. Yeah. So you could use 1% once a week, which actually is 52 drops a year, which is, I think, really safe in a way, if you wanted to as well, if you wanted something really cheap. So that's why I think I was talking to some Indian ophthalmologists, where cost and distance and things is an issue, and that's definitely an option. Just put them 1% once a week, which is what we do for amblyopic children, which are very young. Of course, if the child's very young and you're giving 1%, then you worry about amblyopia. So is it something that we start after the critical age, after 7 or 8 years old, where we're not so worried about amblyopia risks and things? Yeah. So having said that, I don't think our 6-year-old, 7-year-old, 8 years old, and myopic children generally do not get amblyopic. So it might not be so much of an issue. Yeah.
Yeah, Audrey, we this type of high talk, it can last a couple hours. But then I do understand in 10 minutes time you will have a clinic. You got to commence your
Yes,
clinic.
I do have a meeting.
Yeah. Yes. So I just would like to say thank you very much. And then we do have a lot of unanswered questions yet. So we would like to invite you to come back to our interview, the first of sections later, whenever you have time. So
sure, if you have any more. Yeah.
Yeah, thank you so much, Audrey, for spending your time, and it was a great conversation. I've been learning a lot. I'm sure our audience will learn a lot as well. Thank you, Audrey.
Okay. Yeah.
Enjoy
okay.
it. Good day.
Welcome. Okay. Bye-bye.
Bye-bye.